Okay, great. Let's get going then. So welcome to our Tuesday weekly Zoom departmental meeting. And it's a pleasure to welcome Janet Giddy today, who's going to be talking about the unprecedented pandemic, collateral damage. So it's a different take on the COVID pandemic, which I think is going to be very interesting. So thanks to the Social Responsibility Committee for inviting Dr. Giddy, who they write is a family physician with public health experience in HIV, TB, maternal and child health. They go on to say she's the mother of 4 adult children and might have become a psychiatrist if circumstances in her life had been different. But Janet, you'll as you go through your slides, you'll tell us more about yourself. So yes. Thanks again for doing this. Over to you.
Thanks for the invitation, Dan, and hello to everybody. It's quite strange talking to, I don't know how many people and not being able to see you, but anyway, to start off by saying, you can see the title of my talk, but my first thing to say is that when you're talking to psychiatrists, I presume you can talk about your feelings and your fears freely. So I have to tell you, my fear is that my dogs will bark, because that's the problem with doing these things from home, is that you have your animals and your domestic life around you. So if they do bark, just bear with me, because they are now my family. Okay, so I said to Dan I'd do a little bit of a bit more of an introduction. And as I know, and you know, nowadays positionality is all important. We have to say who we are. Dan has already read out the medical persona part of myself. But beyond the medical persona, I'm in that phase of life where our adult children have left home and I have a lot more freedom. And I've used this to actually actively choose to enjoy adventures and engage in interesting experiences. And I've also been exploring writing and creativity in general as ways to process what happens in life, including during the COVID pandemic. And this is linked to an interest I have, which I share with Steve, my husband, in medical humanities, which is all about linking literature, history, art, music, anthropology, etc., to medicine and seeing how it can be synergistic. And it's a whole topic of its own that interests me a lot. So, in fact, why I was asked to do this talk, I think, is that people saw an article that I had published in the Daily Maverick. Actually, it was quite interesting to me how many people saw it. And the title of the article was talking about pandemics, what is unprecedented, and that's a link to the article. And I think in the introduction or the invitation to this talk, you were given this link as well. So actually writing this article was one of the things I would say is part of my medical humanities coping things. Is like when I'm feeling as if life is very crazy and I don't know what's going on and I'm trying to make sense of it, is I often find it really helps me to write. And it can start off in a very vague way. And I've got lots of bits of writing of things that never go anywhere. And then sometimes they do take more shape. And this one did, and it ended up in this article. So what's interesting at the bottom here is these 2 images. So when they said, yes, we'll publish your article, and in fact, what was amazing, if any of you are interested in publishing in the Daily Maverick, between requesting to have it published, getting an answer, and it being published was less than 24 hours. And they asked me to send some images. So they asked me for a photo of myself. So the photo on the slide before this one was the one I sent to them, but they didn't put it in the article. And that's actually a picture of me in Spain exactly a year ago, walking the Camino, having a wonderful adventure, and now thinking, I'm so pleased I did it last year in 2019, not in 2020. So I sent them this image on the left, which is our daughter, who's a doctor, who is also working in the COVID world. And I explained that, but somehow they chose the image on the right to accompany the article and didn't discuss it with me or anything. I just saw the article with that image and I thought, this is really weird. And how they chose it, why they chose it, I don't know. It's a mystery. But I actually said to Steve last night, you know, this is so weird. It looks so alien. So he said, well, actually, our daughter Joanna also looks quite alien. So, you know, maybe the alien image is okay with it. Anyway, that's the article. So just to give a bit of background into my COVID volunteer experiences, I might even call them adventures. Here's a couple of images as well, just to give you a sense. So on the left is my tracking and tracing days. So I spent about 2 months from mid-March to about mid-May, I joined the provincial task team. They called the COVID outreach task team. And I went in there every day and we tracked and traced people with COVID. And what that meant was we got all the positive results via NHLS. And I mean, at the beginning, we wrote their names down and a few things about them and, you know, where they lived, etc. And then we would phone them and talk to them. And it was actually the most fascinating thing, because for me, like many people, COVID was completely new. I knew nothing about it. And it was the best way to find out how COVID affects people. And the spectrum of things from asymptomatic to very sick and including people who die. So I did that for about 2 months until the numbers got so high and the backlog in results was at one point over a week, 10 days, 12 days. It just felt to me like it was no longer a useful thing to do. And then I had my time of reflection, which was in sort of late May, and wrote the article then and thinking about everything. And then I decided I still had some appetite for COVID work, and I was interested to see what happens when people get really, really sick. So I signed up to help at the MSF Field Hospital in Khayelitsha. And I spent about a month quite involved there with both the health systems aspects, clinical aspects, looking at mortality. In fact, my last bit of work with that has been, I'm completing a mortality audit. They're actually closing that field hospital down, as they are the CTICC, which I'll talk about a bit later on. And at the bottom is a picture of the oxygen cylinders. I learned a lot about oxygen, amongst many other things, through that. So it was very interesting. So that's, in a sense, giving you my experience of COVID, which has kind of informed me thinking and reading, as we all have in the last few months. So going to the article, I'm not going to go through it in detail because I really want us to have enough time to talk. So I'm just going to bring up a few key points in the article. So I ask a series of questions, which I kind of answer as well. So I start off by saying, what is my concern regarding the South African COVID response? And right from the beginning, as the lockdown was announced, I just thought we are overreacting. And I tell a little story about phoning an American infectious diseases friend and colleague who lives in Durban and trying to talk to her about it and feeling like she was on a completely different planet. You know, she just told me, you know, I have no idea, this is terribly serious, we have to do all this, etc. And I thought, I'm not so sure about that. Anyway, basically, I felt then and have continued to feel that the South African government overreacted, was over-involved and over-functioned in a sense with regard to it, compared to many other things. And particularly, I compared the response to COVID with TB and HIV. So I then go on in the article to ask what drives the COVID pandemic. And quite a few people have written about what they actually call the panic pandemic. That's what some people call it, the panic pandemic. And in fact, I think of COVID as having in South Africa 3 waves. The actual virus spreading itself throughout the country is the first wave. And the second wave is what I'd call the panic pandemic and all the fear and anxiety that has gone with it. And then I think the third wave is what I'd call the collateral damage. And obviously they all overlap with each other. So I thought a bit about my thoughts about what drives the panic pandemic. And it was sort of, you know, some reflections on where COVID started, the fact that it affects wealthy nations as much as low and middle income countries, the fact that the WHO stepped in, and much as the WHO is a very important institution, and I don't share Donald Trump's views that it's a problem, but I think what is difficult is that they try to go with a one-size-fits-all approach to COVID, and I think that was really quite problematic. And I mean, it's interesting. I found a really, really interesting article by, so I have to tell you this, a psychiatrist, an Indian psychiatrist called Vikram Patel, who's a psychiatrist and researcher, and he wrote an article in The Lancet in which he questioned the appropriateness of the WHO approach to COVID. And I'm just going to read a little quote from his Lancet article. He questioned whether it was appropriate to adopt these lockdown strategies for what he called less resourced countries with distinct population structures, vastly different public health needs, immensely fewer healthcare resources, less participatory governance, and massive within-country inequities and fragile economies, which certainly describes India and South Africa and many countries in South America. Vikram Patel set up the Center for Global Mental Health at the London School of Tropical Medicine and Hygiene, and in 2015 was considered one of the 100 most influential people when they have those sort of surveys. So I think that's a bit about what my thoughts about what drives the COVID panic. But it's one of the questions I'm going to ask a bit later. I'm going to do a bit of presentation, then pause and have some questions, and then if we've got time, I've got a bit more afterwards. So in the article, I then went on to say what is actually going on with COVID scientifically, and just trying to understand what we knew then. And obviously, this is a very dynamic, rapidly, constantly evolving situation, our knowledge of COVID. And that's also part of the problem and the panic, I think, is just we don't know. And when we don't know, we sometimes, some of us, imagine the worst and catastrophize a bit. So yeah, there are questions around its infectivity and the pathophysiology. You know, is it a respiratory infection, or is it primarily a vascular disease or coagulopathy, which is what we know now. It has a very complex effect on people. And for me, also working in the field hospital, I learned a lot there about that, and seeing also how the treatment is changing over time as we learn more about it. And then, of course, there was, with COVID, all the modeling and people trying to work out how bad it could be. And so I write a little bit about models and what they tell us or don't tell us. And I heard a nice quote about models recently where they said, models are all wrong, but sometimes they're useful. Okay, some more of the questions I asked in the article was about the similarities and differences between TB, HIV, and COVID, and noting that they all deservedly are called pandemics. And yeah, I'm just thinking about the history of them, TB being the oldest disease, you know, we've known about it since antiquity, and also just to note that TB is actually the most serious global infectious disease, if we're talking about infectious diseases and global. Every year, 10 million people get TB. And despite it being a preventable and treatable disease, 1.5 million people die from TB every year. And we sort of forget this. We sort of, oh, TB, whatever. So anyway, and then I talk a bit about the infectivity and the transmission, how easy it is to get these diseases, who's at risk. And the fact is that we know with both TB and HIV that people of all ages are at risk, starting with infants, with newborns, children, young people, the economically active, etc. All are very susceptible to TB and HIV, but amazingly, or fortunately, we could say, it seems as if COVID doesn't have as bad an impact on young people and children, which is good. There's also the whole thing of stigma and who gets diseases, and the fact that TB and HIV are already stigmatized diseases. But then I think the bottom question is really interesting, this question of mortality. How lethal or deadly are these diseases? And I'm sure some of you were also listening to the emotive language used in the media and by politicians in South Africa, all over the world, and how they continually referred to COVID as a deadly disease, as lethal, as, you know, as if it were Ebola. So just a few points about mortality, because obviously where there's death involved, there's always a lot of anxiety. And yeah, just to give a bit of perspective, untreated HIV mortality is 50 times greater than for COVID. And even on ART, HIV mortality is still 5 to 10 times more than for COVID. The estimates of COVID case fatality rates are very difficult at the moment, and we'll probably know more in a few months and certainly in a year or two. But, you know, the estimates of between 0.1 to 3%, some people even estimate less than 0.1%. The problem is we don't know what the denominator is, and we don't know how many asymptomatic infections there are. But in terms of mortality of these three pandemics that I compare in the article, we know quite a bit about the others. Obviously, they've been around longer. So we know in South Africa that 2.8 million people are estimated to have died of HIV between 1997 and 2010. And that in the sort of peak of the AIDS time was 2005, where they estimated at least 700 people died from AIDS every single day. And there are people who say those are underestimates. And currently in South Africa, about 200,000 people die every year from TB and HIV of all ages. HIV globally, 75 million have been infected, and there have been 32 million deaths. And just in 2018 alone, there were 770,000. So that's just to give a bit of perspective. And when we're feeling very anxious about COVID, just to remember there are a lot of other infectious diseases out there. So write a bit about the South African government response to COVID. And as I said, it was informed by the WHO, what happened in other countries, and apparently the scientists. Although I think some of the scientists were quite quickly questioning it. And then, yeah. People have called it a harsh, extreme. Even Feral Haffajee called it a toxic lockdown. And she says it was amongst the most, in a way, brutal in the world. We know there were about 250,000 arrests. There was a lot of police brutality. We even had deaths. I think 10 deaths as a result of that. And then, of course, the thing I'm going to talk about more is the collateral damage. I'll come back to that. And I think actually, interestingly, quite quickly in South Africa, the scientists and activists started to question the value of the lockdown. And so it didn't seem as if they were informing the government, but there seemed to be some other considerations there. And then people like Glenda Gray, as I'm sure you all know, got publicly censured. And then there was a whole response to that. I mean, it's been very interesting what's happened in South Africa. So in this article, I got to the end of May and I said, okay, so we know COVID's coming. We know that the storm is there. We've had all the storm warnings and what was coming. And I sort of tried to imagine what it would be like. What would the next few months in South Africa be like? And I wrote about it, sort of saying, imagining, hospitals being really full. And that's actually why I went to the MSF hospital. Was I thought I have to see what it is actually like. I have to see and get involved and do something, not just sit in my armchair and write articles. And so that was it was not $1 million question, $1 million ZAR question on the 9th of June. So now what's wonderful is 2 months later, we can answer the question of how bad will it be? How bad was it? We can actually say. So I've got a couple of graphs here, and I'm sure some of you have seen them if you're on any of those Echo Clinic meetings. These graphs are regularly shown there. And so the number of admissions and deaths. And so what you're basically seeing, the trend here, the one on the left, ICU admissions, you see it went up, it plateaued, it's coming down. The general admissions, it went up, it peaked, it's coming down. The deaths on the right is one of the graphs. Actually, this one is, I think, probably about 2 weeks old. It's the deaths, you see them plateauing. Here's some more data. I'm sure you've all seen versions of these. So the one on the left is the estimate of the number of beds that would be needed, public, private, ICU, etc. But basically, they estimated we need 5,450 beds at peak, but we actually only needed 2,600, and that we peaked. And suddenly everyone's saying, oh my goodness, it's like, it's over. That's why the MSF Field Hospital is closing and the CTIC hospital is closing, is we probably didn't really need them. I think they took the pressure off and so on, but it almost like we might have got away without them. And the daily deaths, the graph on the right, as you can see, the black line is the projected or modeled, what was modeled to be the number of deaths they expected, but it's actually far, far lower, and it's on the decline. Khayelitsha particularly interests me because I worked there for many years and I was involved with the field hospital. And what you see here is the dramatic decrease in hospitalizations. Like, it just plummeted. It was just extraordinary. And then on the right is the mortality as well. So altogether, we have basically got over the worst. And, everyone's breathing a deep sigh of relief. And we're starting to worry a bit about the COVID storm moving to Gauteng in the Eastern Cape. And in fact, what MSF have done is they've been in discussion with various of our colleagues in the Eastern Cape, and they've sent up staff there. They've packed up all the oxygen concentrators, beds. So they actually were able to take their resources and redirect them. And there's a couple of people who've been in Butterworth for the last week or two, helping them set up, build capacity there, and train and get ready for, you know, things being worse there. Because I think quite a few of us must have read with extreme disturbance the stories of what was happening in the Eastern Cape, in some of the hospitals in Port Elizabeth, etc. Gauteng also seemed to be taken a little bit, strangely enough, considering NICD and many other very, very influential and important health institutions are based in Gauteng. They didn't seem to have done quite as many preps as the Western Cape had done. And so the storm, in a sense, hit there a bit later, and they were not quite as prepared as they could or should have been. But actually, it's interesting. So our daughter, the picture I showed you earlier, she works in a public hospital, Helen Joseph, in Gauteng. And I actually asked her last night, because I said, oh, I have to know what's the latest, how are things? And they had quite a tough couple of weeks. But she says it's definitely stabilizing. They're not overwhelmed. They're not drowning. They are sending some patients to Nasrec. They finally got the Nasrec Field Hospital up and running. And they've got some oxygen there. And in fact, there's the person who kind of got that initiative up and going was an old MSF employee that I used to work with in Khayelitsha. So, I mean, MSF are an amazing organization in their responsiveness and their ability to shift and change and do things quite quickly. So it doesn't seem as if things are that bad either. They are hitting the peak later than us, but the peak is not a bit like us. They'll probably look back and say, we thought it would be worse. So it's interesting when people ask me, what do I think of the COVID situation? And I say, well, we're actually over the worst. And instead of them saying, oh, that's good news, they say, what about the second and third waves? And I'm just amazed that people have to still, it's like nobody can receive good news. Not nobody, some people. Okay, so the third wave, as I said, of my concern around COVID is really around the collateral damage. And right from the beginning, we started to see it and track it right from the beginning, that there was increasing poverty, hunger. I'm sure we all know people who've lost jobs or their work has ground to a halt. They don't know what's going to happen, or they've been put on half-time, etc. So I think at every economic level, people are feeling the socioeconomic impact. We know there's chronic meds defaulting, TB, drugs, HIV, etc. I'd be interested to know what information there is around the psychiatric patients and their defaulting medication. There are less visits to clinics for acute care and screening, and I have lots of colleagues who work in clinics, and you know, they've said everything got diverted to COVID and patients were scared to come. Clinics were closed because one or two staff members would have it and they'd get in a panic and have to deep clean the clinic, etc., etc. So for multiple reasons, there were less visits for everything. I have colleagues who work in TB hospitals. I spoke to a person who works in a TB hospital outside Cape Town, and she says they're there, the staff are there, but the patients are not being referred, they're not coming. And there's real concern. What's happened to those TB patients? They are there, but they're in the community. You know, immunization rates are down. Sonia Botha, who's the Western Cape Provincial Maternal and Child Health Director, was on Cape Talk a week or two ago talking about this and very concerned about that. And just for the record, we know that some of the childhood infectious diseases like measles, their RO number, the reproductive index number, is 12 to 18, unlike COVID, which is thought to be around 2 or 3. So we are going to probably have measles epidemics in the next 18 months. We know after the Ebola crisis in West Africa, they had measles epidemics a year or two later. I think the whole issue of mental health is huge for everybody. I mean, I think all of us have had our general low-grade or not so low-grade angst and concerns and fears amplified by COVID. I mean, I'm sure all of you have conversations with your your spouse, your family members, your relatives, your neighbors, and everybody is more anxious. And people are dealing with death and bereavement. So it's a very difficult time in that way. And then the schools thing is a whole topic of itself. And I think we also have created quite an educational crisis. I spoke to my brother-in-law a day or two ago. He's got a son in matric, and I said, what's happening about matric? And he says, nobody knows. There's probably going to be no matric in 2020. And then that has a whole knock-on effect. What will happen at universities, etc. The whole issue of universities. So that's a big collateral damage. So we were seeing these various reports or hearing anecdotally from people about the collateral damage right from the beginning, but I think now people are trying to quantify it. And there was a very interesting report that came out, I think, a week or two ago. Some of you may have seen it, called the National Income Dynamics Study on Corona Rapid Mobile Survey, the NIDS-CRAM study. And there's a list of authors, mostly, well, a lot of them Stellenbosch and UCT. I think the lead author is Nick Spaull, who's an economist at Stellenbosch. So they're now trying to quantify more exactly what is happening, what has happened. So I'm just going to give a few findings. Obviously, people, you can go and read it if you want. And of their respondents who they contacted, 18% had lost jobs in between February and April. And 47% of households had run out of money to buy food in April. That was still in the hard lockdown. From a health point of view, quantifying that, 23% unable to access medication or contraception. Only 78% of those who needed care for an acute condition got to a clinic or a healthcare provider. 10% of HIV positive new and pregnant mothers ran out of art. 1 in 6 mothers and pregnant women reported gaps in care. So those are mothers of children. So we know that there's a lot of collateral damage. What was also an interesting thing in the study was one of the questions they asked was perception of risk, and they came out with this statement that affluent South Africans have exaggerated infectivity perceptions, and in the top quintile, 53% believe they'd get COVID, and the lowest quintile, only 25%. And it's probably the other way around in terms of actual infectious risk. ASAF is the Academy of Science for South Africa, and their Standing Committee on Health on the 2nd of July came out with a statement on the unanticipated costs of COVID on South Africa's quadruple disease burden. And it's about a 3 or 4 page statement, if anyone's interested. And as one of the examples they gave, there was a 48%, the NICD had documented a 48% decrease in testing for TB, as well as a 33% reduction in the number of positive cases. So we know there's people with TB out in the community who are not being diagnosed, not being treated. And well, maybe they won't be spreading it around quite as much with masks and social distancing, but there probably will be more TB as a result. And then the ASAF statement goes on to outline various scenarios and possible impacts of what they call privileging COVID on the quadruple burden of disease, and saying this is a real problem. So so this is a chance for us to maybe stop and talk a little bit. As I said, I've got a few more slides, but I think it's important just to maybe have a bit of input, ask some questions, have some responses to what I've said so far. And I see we sort of got at least 25 minutes, so people can talk for a while, and then I can finish up with my last few slides, which are my thoughts about some of these questions. So Dan, I don't know if you want to lead the discussion. You probably know more of the people.
Sure. So thanks so much, Janet. I mean, I think that's really very thought-provoking, and your experiences are amazing. Vikram, I actually put on the chat, is well known to us because several people actually work with him. I see, Mark, that you've got your hand up, and is that from before, or do you want to go ahead now?
That was from before, Dan.
Okay, great.
Yeah, I'll lower it down. Yeah.
All right, so I'm looking to everyone. I see John Parker's got his hand up. Go ahead, John.
Thank you, and thank you for an interesting talk. I think if we look at the figures, number of infections in South Africa, and if we look at number of infections, we're fifth in the world. It looks pretty bad. When we look at number of deaths, when we look at our experience certainly in the Western Cape, we see this completely other story. We're not nearly as bad as we think it is. Now, taking on board that, the observation that perhaps we're not recording all the deaths due to COVID, I would be interested in hearing how Janet understands that. Why has our death rate been relatively low? And if it had been on a par with European countries, would we be seeing quite a different story? We certainly heard in places like Italy, New York, about, there not being enough graves, there not being enough mortuary space, and so on. So how do we understand that?
I don't know, Dan, if you want me to answer each question as it comes up, or whether to take a few questions. I don't mind either way. I'm happy to respond to that, but
I think go ahead, Janet.
Yeah. So John, thanks for that question. I think that there are many things that we may have some theories or hypotheses about now, and obviously people are going to spend years, if not decades, unpacking and analyzing everything that happened during this pandemic, as people are now doing with the other pandemics that are suddenly becoming extremely interesting to everybody. And there's lots of things I think that may become more clear as we go forward. So, I mean, I think all countries are obviously not the same. They've got different demographics and their population pyramids look different. And we know certainly that in Africa in general, the population pyramid is more like that, with more young people and less old people. In other countries, it's like that or like that. And in Europe, and I think Italy's got the lowest birth rate in Europe, or amongst the lowest. And so they have far more older people, and people look after the older people better in those countries. And so they live longer. And so, I mean, I think just having older populations is one very obvious reason. Yeah, and we don't know about, I mean, people have talked about the protective effects of BCG vaccination in countries like South Africa. And just for fun, as part of my COVID experiences, I signed up for a BCG trial because I actually never had BCG as a child. And that's an interesting hypothesis. So there are all these hypotheses about, about these questions, and we won't know the answers fully for a while. But I think it is to do, to a certain extent, with the population profile and also the comorbidities. But we also don't know if there are other protective factors apart from BCG. So, yeah, I think the jury's out. John. And I think the whole question of deaths and death ascertainment is an interesting question. And we know certainly there was this recent MRC report that showed the excess deaths. There wasn't a good correlation between the excess deaths and the known COVID deaths. And obviously that's something people are talking about and thinking about. In the Western Cape, the gap between the COVID known deaths and the excess deaths is much smaller than the other provinces. And that's, I mean, in some provinces, it's by a factor of 10. So they say have, let's say 300 COVID deaths, but they have 3,000 excess deaths. Whereas in the Western Cape, I think it wasn't even double. So people are asking these questions that maybe we don't know enough about who's dying and where they're dying. But yeah, I think we'll have to see and watch that space.
Okay, there's a chat question from Petrus. I can read it out, or Petrus can comment. It says, the dramatic drop in Khayelitsha, is it real or due to fear about contracting COVID in hospital?
So that's very interesting. I think everyone in Khayelitsha, the reason why they built the field hospital in Khayelitsha was they wanted to be in the community, MSF, that they've worked in for years, where they feel like they have a lot of already credibility and buy-in, etc., and are seen as a trusted NGO. And if you look at the admissions to the hospital in general, throughout May and June, they were increasing. And then the admissions dropped off dramatically. But this is a pattern across the metro, so it's not specific to Khayelitsha. I just happen to have those Khayelitsha stats because I've been involved there. I think the decrease in numbers, hospitalizations, ICU deaths is across the metro. It's a similar pattern. I mean, my theory about what happened in Khayelitsha, and when people ask me, I say, well, this is what I think. I mean, we don't know, is that I think it spread very quickly through Khayelitsha at the beginning. You could see that. And I know because at that time, we had the first cases in April, and we were doing the tracking and tracing, and we were phoning people. And so I got a really good sense of how people were behaving in Khayelitsha during the early days. And the lockdown was really, truly very, very, I'm not going to say people ignored it or didn't take it seriously. It was actually impossible. The way people lived and their lifestyle and their conditions made it really difficult. And so I think it spread pretty quickly through Khayelitsha. And I think what happened there was, I think several scenarios. Either people are somehow immune to it, and we don't know what percentage of the population are immune for whatever reason, or they got it and they were asymptomatic, or they got it and they were a little bit sick. I mean, and so I saw those kinds of patients, I came across those sorts of scenarios when we phone people. You'd have an outbreak at the Checkers or the magistrate's court or whatever, and you'd phone, and half the people were completely asymptomatic. So they're asymptomatic, or they were mildly ill. They had a flu-like illness, but it wasn't that bad. Or they were a bit sick and they were admitted to hospital, or they were even sicker and they were admitted to ICU, or they were even sick and they died. And so I think that's what happens. I think most people were exposed to it rather than people could protect their elderly or their vulnerable populations like you can in Newlands or Bishop's Court or, the Atlantic Seaboard. You can, and I know people, and I'm sure you all know people who have very successfully managed to hunker down and not go out and have all their groceries and everything delivered, and they have not experienced the virus. Well, they've protected themselves, but you can't really do that in Khayelitsha. So I don't think it's that there's lots of sick people, and I mean, they're community health workers. I have a lot of contact with the Department of Health. I think people have encountered the virus, and one of those things has happened.
Great. Henk has got his hand up.
Thanks, Janet, for a very nice lecture. I just want to ask you, what is your view about medical practitioners and medical professionals in general's training, particularly with regards to evidence-based medicine? Because we know one of the sort of core principles is your risk or your harm should not outweigh your benefit of any intervention or any treatment. And when this pandemic started, I sort of thought this is going to be one of those scenarios where people are going to push the benefits of, locking down to the nth degree, and they're not going to look at harm. Your views on that? And the other thing is, I mean, I've done guidelines with national government, and it's a very frustrating process. You usually get the impression that they are very keen on actually endorsing scientific views, and they're all about science, but when it comes to the actual crunch, it's really about politics, not about science. And it's quite sort of depressing really in that sense. The other thing is really with regards to our sort of maybe internal, I've had to close my ward, which is a ward that caters for people with anxiety, depression, personality, substances. So that's kind of minimized in psychiatry even, that's not really psychiatric illness. Schizophrenia is a psychiatric illness. Addiction, that's really not a psychiatric illness. So there's also that aspect, I think, which we are kind of guilty of ourselves. I suppose you can make an argument, it's, if you need involuntary treatment, that's obviously essential. But, there's also that thing in psychiatry that's sort of concerning, I think. It'd be interesting to hear your views.
Henk, you've brought up quite a few issues there, and all interesting things. I mean, just the last thing you talked about, closing the ward. I suppose I wonder why you closed the ward. Were you instructed to? Were your staff all sick, or
well, I mean, I think we needed space for obviously the big thing in these pandemics. You need space. You need space very quickly. So that was really a PUI ward, a person-owned investigation unit, and then became a COVID sort of site.
Yes.
So, but yeah, I mean, that's really the reason why we had to close. And I was quite happy to close quite quickly, but you know, you start thinking about that afterwards, and you start wondering, and there's a lot of resentment among staff as well. You know, feel that why should our patients now kind of be the ones that are shortchanged? Anyway.
Yes, no, well, I completely agree. And I mean, I think going back to your initial question of risk versus harm, I think that we've probably caused more harm than we have mitigated risk. And I think various people are saying that in various ways. And if you look at that ASAF statement, you know, that is very clear. And that's why people are wanting to document it. I don't think that was considered. And once again, I think it's about fear and panic and people making irrational decisions at the time. But yeah, and I agree with you about politicians and their agendas and not always listening to scientists. So what's been really hard to work out is what is driving Zweli Mkhize's agendas and decisions. You know, he refers to the Ministerial Advisory Committee, and occasionally Slim Abdul Karim says something, but it does not feel as if it's been driven by the scientists. It feels like it's been driven by the politicians. And we see a lot of the irrational decisions, the flip-flopping around the schools, the taxis, like who's got more political clout will drive the decisions made, and all these trade-offs. So I don't think it's scientifically based at all. I mean, in the article I write about Iceland, or obviously Iceland's a small place and it's all quite contained and you can do things very differently than a big messy country like South Africa. But they basically let public health people drive their COVID response completely and not politicians. And there's some very interesting quotes about having humble experts leading the response to a pandemic as opposed to politicians. And so I think we have suffered from gung-ho politicians with all sorts of other agendas. And I don't even want to talk about all the recent stuff around, you know, corruption of the COVID tenders, et cetera, et cetera. And I think all the conspiracy theorists have also kind of had a bit of a field day about, you know, what's really happening behind the scenes politically. Yeah, I mean, I think the one thing that's been interesting has been the whole alcohol ban, and that's a whole subject of itself. But we've had, in a way, a controlled experiment of what happens when you reduce access to alcohol. Cigarettes, another story. But anyway, I think you brought up a lot of things, so I've just tried to touch on a few of them. And it does worry me that the scientists have not had as much of an influence as they should have.
So, I see there's one hand up, but I just want to ask one question or two myself. I suppose you said this hasn't been driven by scientists, but there's also the issue of scientists getting it wrong, and I'm not quite sure where you fall on.
Yeah.
I mean, so I'm looking at an article in the New England Journal of Medicine by Slim Karim, and it certainly seems that at an early point he was very influential, and he had a very particular approach, which involved the lockdown. And it looks from the New England Journal of Medicine article that he fully supported that, despite the consequences. The second, so so I'm not sure if I've misunderstood him in some way. The second is the WHO. They seemed slow to get going, is my recollection. I could be wrong. They were very slow to support the use of masks. I see Iceland themselves has only just started using masks, but that seems to be a very important feature in many other countries. And WHO did not regard this as an aerosolized transmission disease, and for a very long time, for reasons that are unclear to me. And so have we as the health profession got it wrong, or as always the politicians?
Yeah, I agree, and I think you're absolutely right, Dan. It's also a problem of a rapidly evolving situation and working on best evidence and, playing it safe and being cautious and things like that. So that is true, that the scientists haven't always known. And also trying to, I mean, I think one of the things that, the thing that comes home to me all the time is this thing of the one size fits all, that we think that there's an answer that's suitable for everybody. Even in South Africa, I think with the school issue that is so contested and so emotional, they're trying to have a one size fits all response as well. And I think the provinces differ, different countries differ, and within a country, the in-country differences as well. And I think that if there was, I mean, I think that the paradigm of controlling people is very, very dominant in South Africa and in certain countries. So yeah, it's very difficult. I mean, one of the things I've seen that's been interesting is showing that countries that have dealt with COVID in a way more successfully or in a more constructive way have been mostly led by women. So I think that's also an interesting topic. You know, women's approach of nuance, complexity, to maybe not trying to, I don't know what, be so gung-ho or something like that. But that's a topic of itself. I'm seeing that there's about, by my clock, about 7 minutes to go. And I'm wondering if I should, no, 10 minutes to go. I'm wondering if I should show the other slides and then maybe we have a bit more discussion at the end. What do you think? Unless I can't see the questions, if there are any more questions.
I think that's fine, Janet. And actually, you just answered the one question which I was going to ask, and maybe you'll address, which is, well, what would you have done if you'd been in charge? You kind of alluded to that a little bit, but please, I think go ahead. If there are only 7 minutes, then please go ahead.
Yeah, so I'll just show you some of these, and then maybe I'll see if there's more that anyone wants to ask or say. So in the article, I wrote a thing called what if, because I consulted a few people about this article. I've also learned as I get older is that harnessing different people's ideas and input is very, very helpful. And actually the article was very shaped by many of the people who I consulted, who included members of my family. And what's wonderful is when your adult children can give you feedback on your writing style, you know, and like my one son, who was a professional athlete for many years, now biker boy turned banker boy, saying to me, Mom, you can't put it like that. You know, that's just too extreme, and you've got to moderate it and modulate it. Anyway, it was very, very interesting, the kids' input. And my daughter's partner also gave me a whole lot of input, and he came up with this phrase, what if? So, so Dan, in answer to your question, what would I do? I would go back and look at history. And just wait, my dog's scratching. Because that's what I've also learned through my sort of interest in medical humanities, is we can learn so much from other disciplines. And so I looked at a whole lot of different pandemics in the last 100 years, or just over 100 years, and looked at the deaths, the case fatality rates, etc. And it's really, really fascinating. I mean, I've known about the Spanish flu for a long, long time. And there's an expert in the Spanish flu at UCT, Howard Phillips, and he's given some very interesting webinars where he's had conversations with virologists and various other people around what happened, why it spread, what people did, what they didn't do, etc. So, sorry. So I'm not going to go through the slide in detail, but I'm just giving the point that we can learn how we learn. So there's scientific evidence, but there's also historical precedent that I think is interesting. So the two pandemics I want to highlight is actually, people will remember these recent ones, SARS in 2002, swine flu, MERS in 2012. But what's really interesting that I knew nothing about till I started doing a bit of broader reading is that in 1957 and in 1968, there were two massive flu pandemics that spread throughout the world, a bit like coronavirus, as in like they affected millions and millions of people. You can see there they were caused by different viruses, H2N2, H3N2, and they caused about as many deaths as we may have with this pandemic. For example, between 1 and 4 million deaths, each of them, it's estimated. And obviously in those days, they probably couldn't, what can I say, have such definite diagnostic criteria. But anyway, it seems like there were a huge number of deaths, but the case fatality rates were relatively low. And if you reading about those pandemics is really quite fascinating. A bit like this COVID, they both originated in Asia. So far with this current pandemic, it's estimated, I looked at the world odometer last night, approximately, I rounded off, approximately 18.4 million infected, with so far 695,000 deaths. Okay, so that's quite a bit below those pandemics. And in a given normal year, WHO estimates between 200 and 650,000 people die of seasonal flu. So, okay, there's still a bit of time to run on, and there probably will be more deaths than seasonal flu. But this pandemic may be looked back on in history in maybe 50 years' time as not being that much worse than 1957 or 1968. But the fascinating thing is what they did in those days. And did they like try and stop the whole world, the economies, the airlines, the transport, etc.? They didn't. And so I think maybe what we'll learn from this is, like, don't make the treatment, the cure worse than the disease. What the question, John, no, I think Henk asked at the beginning, the risks versus the harms. And so I found this interesting article by a guy called Simon Jenkins, who had this quote. He says, "When hysteria is rife, we might try some history." And he, in the article, he gives a whole lot of examples of, people getting a bit, what I think he calls hysterical. He says in 1997, we were told that bird flu could kill millions worldwide. Thankfully, it didn't. In 1999, European scientists warned that BSE would kill 500,000 people, etc. And so I think what's happened in recent years is that the modelers have got sort of more more bold in their modeling. And so I think, and social media, etc., etc. And so I think a lot of things have driven this pandemic. And we've had these pandemics before, and we have not done what we've done this time. So I think in answer to the question, I think I wouldn't have had the sort of lockdown that we've had. Just a few last thoughts here. Edwin Cameron wrote recently, he said about COVID, we've reenacted many of the mistakes of AIDS. And also comparing it with AIDS, saying that those who are most vulnerable socially and economically are the worst affected. And he made the point, strong arm tactics are the wrong approach to a public health disaster. This is a Mark Haywood article that I've referenced here, a very recent article. And I think that article is worth reading, called What Went Wrong and What Will It Take to Fix It? And he talks about the fact that health is not like COVID. It's not a standalone thing. It can't be isolated, and brings in this whole idea of social and economic determinants, which is what we're seeing now. We're seeing this pandemic of deprivation and social misery. But he comes out with quite a positive statement at the end, saying South Africa's at a crossroads and that we should mobilize our strengths, and despite everything we can overcome it. And I guess I like it because that's a bit how I feel. We mustn't give way to pessimism and despair. ASAF had a bit more to say in their statement. They said, until we have a vaccine, COVID-19 may be amongst us for quite some time. Yeah, and I don't know, I'm not pinning my hopes on a vaccine. I suppose I'm pinning my hopes on us all calming down and, in a way, learning to live with this virus, as we've learned to live with many viruses over the millennia. They also say finite resources cannot be diverted solely to the pandemic, and we really have to do some careful priority setting and look at what we still need to keep going. So I think that that ward for the patients with anxiety must be reopened ASAP. Yeah, and then just so we have to balance these things. We've still got the ongoing COVID, and I don't want to minimize the fact that it's serious. It's just, I think, how we, like everything in life, how we find balance, and have we done the best we can in the simple primary healthcare ways? So here are some suggestions also from Mark Haywood: deploy community health workers more effectively as service linkers, get more community engagement, and look at changing social norms, be much more clear about the key prevention behaviors, the mask wearing, physical distancing, distribute the masks and information, flyers, etc., and have clear, concise, consistent communication. And particularly around key symptoms of COVID, and anchor the messages in hope and a positive vision for the future. And I listen very carefully to messages of politicians, and it does distress me, the sort of and the way people talk, and whether it's the teachers union or whoever, like the catastrophic and very negative and very emotive language that is used, that I think spreads the fear and anxiety. Anyway, that's my last slide. So I see we're sort of almost out of time, but any further thoughts that people may have or questions?
So I'm just, Janet, just looking at some of the chat stuff, and there's no hands up, but people are thanking you. Perfect example of truly responsive healthcare, superb provocative talk, very interesting, thank you. So I can't say it better than that. If I can be permitted just a little bit of editorializing, you know, there has been in the mental health world quite a lot of stuff about how this is going to make us, and has already made us very depressed and PTSD and a lot of that stuff. And I found that tricky because the principles of psychiatric management at the time of a disaster are, in fact, to emphasize resilience, to point out that most of us manage quite stressful things without getting overly anxious. You know, some anxiety and some depression is entirely normal, and that's just part of normal coping. And that we at this time need to convey a message of hope. So very much resonating with Mark Haywood and with your own message that you know, we can only do better. So thanks very much. I think Mark has got his hand up, and as a social responsibility person who was involved in the invitation, let me hand over to him.
Thank you, Dan. Thank you, Janet. Yes, thank you on behalf of the Social Responsiveness Committee for accepting the invitation and giving us a really superb talk. The article on which it was based was published on the 9th of June, and reading it again last night, it felt like, you know, I just read it yesterday. And it occurred to me that time is, you know, we're living in a very accelerated time. And this is partly because there's so much information in the context of the pandemic, which is changing all the time. And a lot of it, of course, becomes redundant. But I think that's the opposite in your case. I think that your argument, although it was made 2 months ago, is more relevant, you know, now more than ever, as this lockdown gets longer and longer and becomes more and more difficult to justify, as you've argued. So yeah, so on that note, again, on behalf of the department and the Social Responsiveness Committee, thank you so much.
Great, thank you.
It was a pleasure and a privilege to speak to you guys, and yeah, stay well.
Great, thank you.